Hi, my name is Bert Sapicki, paramedic intern, taking paramedic this year, and I just wanted to make a quick summary and quick explanation of DI and its two off-branching components, RSI and DSI. DI means Delayed Administration Intubation. This branches off into two categories: Rapid Sequence Intubation, RSI, and Delayed Sequence Intubation, DSI. But before we get into that, we want to talk about the indications of intubation, the 9 P's of intubation, and the goals of intubation. There are 4 indications of intubation. The first indication is the patient can't ventilate. This means they cannot bring air into their lungs and start gas exchange, which leads us to the second indication of intubation, which is they can't oxygenate. Not being able to oxygenate doesn't allow the capillaries to exchange oxygen and carbon dioxide to the tissues, leading to cellular death. The third indication of intubation is they can't protect their own airway, whether it's from swelling, their lack of consciousness, lack of breathing, anything like that, or just anything lodged in the airway. They can't protect it, basically. They can't allow air in, they can't allow oxygenation. Number 4 is that we can't predict it. Now this one has to do with the paramedic themselves. This is one we use mostly because obviously we can't predict most things. While we can predict some things and small things, sometimes it's very hard to predict whether an airway will collapse or fail, and that is why we intubate. Those are the 4 indications of intubation. Now we're going to get into the 9 P's of intubation. The first P is to plan. Plan out your procedure and how you're going to do it. The second P is to prepare. Get all your supplies, gather everything you're going to need, and get ready for this. Number 3 is protect the C-spine. As with all of our treatments, we always want to protect the cervical spine and limit movement of that in order to secure the patient's spine and stabilize it to prevent injury or further injury. Number 4 is positioning. We always have to position the patient properly when doing these intubations. The most common way of positioning a patient is the sniffing position, as this allows us to easily access the vocal cords and the epiglottis to be able to insert our tube and perform our ventilations. Number 5 is pre-oxygenation. This states that we want to get their oxygen as high as possible before doing any of these procedures. While this is less common in RSI, because RSI I will get into later, but commonly RSI is a rapid sequence intubation, so we have to do it fast. Pre-oxygenation is way more common in DSI, as we have time and management skills to be able to perform pre-oxygenation adequately, but still pre-oxygenation is used in RSI. 6, pre-treatment. These are our sedators, our induction agents. This allows us to pre-oxygenate the patient, tell them what's going on, tell them how we're going to do it, explain everything, give them pain meds or analgesics, and induction agents in order to calm them and get rid of that pain that they're going to feel and that anxiety. Number 7 is our paralysis. Paralysis is, as it sounds, we use paralytic agents in order to paralyze that body, to reduce bronchospasms, get rid of the gag reflex and stuff like that, just to ensure our patient is comfortable and cannot feel anything we're doing and that they are relaxed. Treatments of intubation that don't do paralysis have a much higher fail rate than the other ones do, resulting in bronchospasms, aspiration, and just stuff like that in general. Number 8 is the movement with proof. This means your first step of checking the movement of the lungs is you're going to put your stethoscope on the gastric region just to ensure there's no air down there that would cause aspiration. Then you move to the left lung, because if you didn't know, the left lung is much easier to avoid. It's much easier to go into the right lung, so the left lung may not be moving and have gas exchange after you intubate, which means you need to back out some. And then we move to the right lung just to be sure. Number 9 is post-intubation management. This is oxygenation, ventilation of the patient, and managing their vital signs and improving them every step of the way. And the 3 goals of intubation are to sedate, analgesics, which are pain meds, and paralytic agents we use to ensure the patient is comfortable and not moving. Now we're going to get into RSI, rapid sequence intubation. The 2 major components are to induce immediate unresponsiveness with an induction agent and a paralytic, as we just talked about. 2 is the cessation of spontaneous ventilation, induces considerable risk if the provider does not intubate/ventilate the patient in a timely manner. We do RSI when we don't have that much time, but we still have to do it in a timely manner as we need to ventilate and oxygenate this patient. Now to talk about DSI, delayed sequence intubation. Number 1, procedural sedation, where the procedure is pre-oxygenation. DSI mainly focuses on pre-oxygenation for a while, talking to the patients. This is used more commonly in patients who we can't really predict whether their airway is going to collapse, but they're still talking with us, they're still there with us, and we don't feel the need to be in such a rush. As RSI is used whenever we need in a rush and patient needs an airway immediately. Number 2, DSI may be useful in a patient for whom RSI would inevitably result in significant hypoxemia because they cannot be pre-oxygenated by any other means. As I stated earlier, RSI has a very small window to be able to be performed because it needs to be immediate. So if you think about that, pre-oxygenation wouldn't work too well with RSI as we have less time. However, DSI, when we do have time, we are able to pre-oxygenate this patient up to 100%. That is our goal, 100% oxygenation, which allow us to do these procedures. Now to talk about the drugs. There are 2 types. There's induction and paralytics. As you can see, these are induction drugs. They are ketamine, which is 1.5 to 2 milligrams per kilogram of the ideal body weight. Etomidate, which is 0.3 to 0.4 milligrams per kilogram total body weight. Fentanyl, 2 to 10 micrograms per kilogram total body weight. Midazolam, which is 0.1 to 0.3 milligrams per kilogram total body weight. Propofol is 1 to 2.5 milligrams per kilogram ideal body weight plus 0.4 times total body weight. And then thiopental is 3 to 5 milligrams per kilogram total body weight. And those are induction agents. Now we get over into our paralytics. Our paralytics are hexamethylcholine, which is 1 to 2 milligrams per kilogram total body weight. Rocuronium, which is 0.6 to 1.2 milligrams per kilogram ideal body weight. And vecuronium, which is 0.15 to 0.25 milligrams per kilogram ideal body weight. Now, what are the difference between these 3, you might ask? Sux is a depolarizing agent, which means a depolarizing agent binds to the acetylcholine receptors and invades the neuromuscular junction. Depolarizing agents often cause muscle rigidity and seizure-like symptoms that don't allow so this leads to them being less commonly used. However, Vec and Roc are non-depolarizing agents, so they still bind to those acetylcholine receptors, inducing paralysis, but they don't cause the muscle rigidity as a depolarizing agent would. So these are more commonly used because of the sense that they are non-depolarizing agents. Now, I hope you enjoyed it and I hope you learned something today. My name's Bert, and this was Delayed Administration Intubation, DI, in its 2 forms, RSI and DSI, and all the indications, all the P's, and all the goals. Thank you.